Over the course of today and tomorrow, you're going to be introduced to all kinds of themes congregating around the idea about how to support people better in late life, both in their living and in their dying. I can't think of a better time in Canada to address issues of late life. In Canada, the social and political radar are changing and are squarely focused on issues facing aging Canadians. Today, I'm going to be focusing on those people and their families who are affected by life-limiting illness. From a social perspective, Canadians are beginning to see the need for creating systems of care that lead to a dignified death. Pending medical aid in dying legislation is causing us to not only consider individual rights and freedoms, but also, I hope, is prompting us to consider and reconsider how people with life-limiting illness are treated or not treated in our society. There is clear evidence suggesting that our healthcare system is not adequately addressing the needs of people who are dying and their families. While it is true that there have been tremendous strides in the care of the dying since the inception of the modern hospice and palliative care movement, report after report regrettably concludes that care at the end of life and access to good quality palliative care is the luck of the draw rather than a basic entitlement. It is a sobering realization after almost 30 years of working in the field that many of the same issues exist, despite strong advocacy, educational, and research efforts. We have all heard of the graying tsunami that we face as the baby boomers age. And while I agree with my colleague, Dr. Nina Chappell, that we are not in a crisis and the aging of the population is not going to bankrupt our healthcare system, our population shift does pose a number of major social and health policy challenges. Of interest here are the challenges that we face as people age and come to the end of their lives. If you haven't read this book, it is a book that you ought to read, as Atal Gawande reminds us in his most deeply urgent message. Medicine has triumphed in modern times, transforming the dangers of childbirth, injury, and disease from harrowing to manageable. But when it comes to the inescapable realities of aging and death, what medicine can do often runs counter to what it should do. I have been asked to introduce the idea of aging in place and dying at home to frame our thinking as we move into the conference. I'm going to briefly trace the historical evolution of the idea of dying at home and consider what dying at home looks like in contemporary society. I will suggest that while dying at home is a much hoped for by the large majority of Canadians, achieving this desire is much more problematic and one that is framed by core ideological assumptions. In laying this out, my hope is to inspire us to more thoughtfully consider what it means to die at home, so that we may together evolve our systems of care in a way that is respectful of both those who are dying and their family members. Dying at home is not a new phenomenon. For years, many cultures have supported the idea that people should remain at home to die. But experience of death and dying have changed dramatically over the years. From the early 1900s until around 1950, dying in Canada was mostly seen as a community event, and the home considered a natural gathering place to bear witness to the dying experience. As Aries noted, the death of each person was a public event that moved, literally and figuratively, society as a whole. As such, death had a familiar face for adults and children alike. This is not to say that dying and death were peaceful during this time. Death was often painful and abrupt. By mid-century, the location of death had shifted from home to hospital. By 1950, over half of all deaths took place in hospitals in both the US and Canada, a sharp contrast from the 1930 figure of 30%. With the development of modern medicine, death was perceived as a failure by health professionals, and many began to view death as the enemy of life. Institutionalized death, which had become the norm, was increasingly complex and highly dependent on medical technology in an effort to preserve life at all costs. As Smith and Nichols say, modern healthcare in the affluent post-war years was invested in saving lives, not improving care at the end of life. Death, once seen as a social and community event, became largely an individual event in hospital, with restrictive rules and regulations, oftentimes preventing families from even seeing their loved ones. Many people have argued that this segregation of death is profound for society and families. People were no longer present at the time of death, and as such, death itself became shrouded in mystery and fear. Most people, even today, have not seen somebody who is dying or not seen a dead person until well into our middle age. There have been many trends that have emerged since that time that have influenced aging in place and dying at home. Around the 1960s and 70s, those who had first-hand experience of the loss of family members began to question why dying people were being abandoned in hospital and subjected to sometimes extreme and unnecessary measures when death was inevitable. They found their champions in a number of pioneers of death and dying that would become the hospice and palliative care movements. Perhaps most notable in the North American context was Dr. Elizabeth Kubler-Ross, an American psychiatrist who promoted the concept of providing psychological counseling to the dying. While her well-known theories of the stages of dying have been subjected to critique in recent years, she is prominently acknowledged for bringing discussions of death and dying back into the public domain. The modern hospice and palliative care movement traced the origins to Dame Cicely Saunders, who introduced a new way of treating the dying, which she called hospice care. Saunders was a trained nurse, social worker, and medical doctor, holding that human beings should be able to die with dignity and at peace. This viewpoint originated from her medical experiences in working with the dying and also from her strong religious commitments as a Christian. Saunders founded St. Christopher's Hospice in 1967 in London, England, and began a program of care for the dying based on 3 key principles: pain and symptom management, a family and community environment, and an engagement with a dying person's most deeply rooted spirituality. In his definitive book on Saunders' life and writings, David Clark notes that she laid down the basic principles of modern hospice care: systematic pain control in terminally ill patients with close attention to their social, emotional, and spiritual needs. Inspired by the work of Saunders, Dr. Balfour Mount, a Canadian surgeon, was the first to study the needs of dying patients in Canada and was appalled by what he found. This prompted the establishment of Canada's first palliative care programs. Most initial palliative care programs in Canada were hospital-based, but healthcare reforms in the 1990s and resulting deinstitutionalization meant that many people, including those who were dying, were expected to be cared at home by family members. Dying at home became widely advocated by policymakers and practitioners alike, who maintained that people who were dying preferred to spend their final days at home in familiar, comfortable surroundings and preferred to be cared for people like their family members and those closest to them. This is consistent with a report from polls of Canadian seniors. The Canadian Institutes for Health Information report that 93% of Canadian seniors live at home and want to stay at home as long as possible. The reality, however, is that most Canadians die in hospital. And I don't know if you can see, but the light blue color on the bar graphs indicate the percentage of people dying in acute care hospital. That doesn't include the number of people also that die in residential care facilities. There are many factors that contribute to high rates of hospitalization. Medicalization of aging and dying accounts partly for the ongoing reliance of hospitals at the end of life. The shortage of family physicians in many regions of the country and the reluctance to do home visits, which are often necessary to promote dying at home, also account for the hospital admissions. A lack of advanced care planning that would facilitate conversations about end-of-life care and allow for the proper planning and supports needed to allow for a home death greatly contribute to hospital admissions at the end of life. And if you haven't come across www.advancedcareplanning.ca, please go to that website and do an advanced care plan. Your family will thank you for it. But I would submit that it is the inadequacy of home care and other forms of support for families that pose the greatest challenges to facilitating quality end-of-life care at home. Death and dying not only affect the person who is dying, rather dying at home impacts everyone in that person's circle of care: spouses, parents, grandparents, children and grandchildren. And as I will touch on later this evening, what about those who do not have homes and family support? In the almost 30 years that I have been in palliative care and been a palliative care nurse, I have witnessed the most amazing experiences of people dying at home. I also know of many situations that have been profoundly difficult. I will talk more this evening about some of the joys and challenges of family caregivers of the dying when care is provided at home. But for now, I'd like to focus on some key assumptions that seem to influence how dying at home is taken up and that are somewhat problematic. Assumption 1, your family can take care of you. Healthcare systems in North America seem to operate under the assumption that family members, particularly women, are able and available to provide care. However, the reality of geographic and employment mobility mean that adult children often live at vast distances from their aging parents when they are in need of care and support. In addition, lower birth weights mean that there are fewer children available to provide care. As well, most men and women, the vast majority, work full-time and have multiple responsibilities, including caring for their own children while caring for their aging parents. People who are dying at home are all too aware of the impact that their need for care may be having. Fear of being a burden to their family is one of the principal reasons that people consider ending their own lives. Assumption 2, home care will be available when you need it. Most families assume that they will have access to home care when they have a family member that becomes ill. Almost all caregivers in my research tell me that they believe the healthcare system will be there to support them when they need it, and to the extent that they need. Some believe that they will have access to a nurse coming into their home 24/7. Unfortunately, they sadly become aware all too soon that sometimes supports are not there when needed, and home care is not considered an essential service guaranteed under the Canada Health Act. The services provided through health authorities vary widely across the province, and access to quality home care and palliative care is hit and miss depending on where you live. While some jurisdictions provide 24-hour access to support people at the end of life, others offer very limited support. As needs escalate beyond available services, many people are forced to go to an acute care hospital despite their wishes to be at home. Assumption 3, one big happy family. Media representations of dying also sometimes project romanticized versions about what it is like to die at home. Multi-generational families arrive in time for the final exchanges of meaningful messages at the bedside before the dying person peacefully slips away. Do you remember terms of endearment? But in reality, family members might not have seen each other for a long time. Sometimes family members don't get along, and they are thrown together in what is arguably one of the most emotionally taxing experiences of their life. Family tensions are greatly exacerbated when families have not discussed matters of end of life, unfortunately common in North America. Unequal sharing of caregiver roles is another tension, and dying people themselves, they're not always reflective, they're not always grateful, and they're not always at peace with what is happening. Oops. As one wife of a dying man said to me, I think most of the emphasis on home care, there's too much that you see on television where people are dying of terrible diseases, but they die slowly and gently, and there's no bedpans involved, nothing like that. That June Colwood got together 60 people to help this woman die at home. Well, that's pointless because the average person hasn't got 60 people that they can call together. And my husband would have been appalled if there had been 60 people tramping in and out of our house. I think the other side is that we deal with TV stereotypes, and the dying person on TV is always warm and gentle and peaceful and loving. He wasn't, my husband. He was raging against this and didn't want this to happen to him. I mean, it wasn't like Love Story, that's for sure. But that's the idea I had in my head. Home is a source of peace and refuge. With few exceptions, most of what is written about the provision of palliative care at home focuses on the benefits of the home setting as the primary location of care. As Armstrong and Armstrong submit, homes are seen as havens from the heartless institutional world, the place where treatment and care can be combined in a safe setting that offers comfort, independence, and choice. Care in the home or community is assumed to be better for virtually everyone and to be preferred by virtually everyone. Yet homes are often transformed in the case of dying at home. Once a restful and peaceful environment, the home is often recreated when palliative care is provided there. Dining rooms and living rooms, once used for social gatherings, become hospital rooms filled with medical equipment and supplies. The refrigerator becomes a receptacle for medications, along with a place to store family nourishment. And the telephone, once used for social interaction, becomes a mechanism for organizing and coordinating health care. Maintaining privacy, intimacy, and self-determinations, hallmarks of a normal home life, can sometimes be eroded when the home is visited by multiple care providers, all offering support and guidance in their own unique ways. Family caregivers often reinvent themselves to become nurses as they try to keep up with the pace of caregiving. I don't want to conclude on a downer note. I want to be sure that you leave this room knowing that as we age and think of our own life and death and where we want to die, almost all of us would say we want to be at home. There is little debate that dying at home can significantly contribute to the overall quality of life of people and their families, and dying at home can be the most wonderfully meaningful and healing experience for families. But I've come to understand dying at home is much more complicated than has been typically represented. Under ideal conditions, dying at home would result in life-enriching experiences marked by negotiated decision-making, careful consideration of family caregiver needs, respectful interactions with healthcare providers, and equitable access to high-quality home care and high-quality palliative care. These are necessary components to facilitate dying at home. With adequate support, the home can provide a much sought-after alternative to a hospital death, at least for those who have access to a suitable home in which to die. But if dying at home successfully, if that makes sense to you, it requires much more than access to home care services. It requires integration of palliative care within those services. Studies have shown that palliative care involving skilled communication about what to expect, attention to pain and other symptoms, and to the stress of serious illness for both dying people and their families actually helps people live their life longer. Early integration of palliative care actually helps people live longer. Such patients are more likely to find life worth living, and the fact that they are spared pain, depression, and family exhaustion means that they also spend less time in hospitals. Not only does palliative care help people live a better quality of life up until the time that they die, but it costs less and also leads to much better outcomes for people at the end of their life, since hospitals are the most dangerous setting for frail, older, and seriously ill people due to antibiotic-resistant infections, medication errors, procedural complications, to name a few. The lesson Gowande writes is almost Zen. You live longer only when you stop trying to live longer. Despite our efforts to deny and defy death, it does in fact come to us all. Death remains for most of us still too terrifying, too final, and too inconceivable to think about. Given the powerful evolutionary pressure to avoid death at any cost, our distaste for the subject is predetermined, no matter how many pundits advise us to think otherwise. But does this primal denial of death mean we have to accept the status quo? The unacceptably high rate of deaths in hospital, the revolving door in and out of emergency departments, and the misery surrounding the process for many patients and families alike. Those are the questions that I leave for you as we move forward with this day. Thank you.
Thank you very much, Kelly, for that really interesting and thought-provoking talk. We've got some time for questions and answers. 5 minutes before coffee. Does anybody have a question? Thank you.
My name is Catherine Willett. I work with family caregivers. I don't have a question. Rather, I want to thank you, Kelly, for a beautiful presentation. And I especially appreciated your list of the different factors that work against dying at home. I know that at Doctors of BC, they're saying one of the things is often what happens is an older person or someone wants to die at home, but the family doesn't always want that. And then there's very difficult conversations that aren't always resolved. Or the other thing is the family is willing to try having someone die at home, but because of the lack of support, it just doesn't work, and the person ends up in a hospice or a hospital. So thank you for sensitizing us to the issues.
Thank you. I just will comment. You know, what often happens for people is one of the primary motivators for many people when they talk with their families about wanting to die at home is that they've often had not very good experiences in the diagnostic period. and they've often been in hospital, and often the person with a life-limiting illness will say to their family member, please don't ever take me back to the hospital, and the family member will say, of course, I will not do that. And these promises to care become kind of strong obligations, and it's very difficult at that point to actually, a family member to actually go back on those promises. But I'll present, when I present tonight, one of the things, we did a study looking at, we compared family members, dying people's preferences for dying at home and their family members, and they're quite different. So while many people would prefer to die at home, more families are reluctant about that because of the challenges and the fear of what is going to happen. Yeah.
Hello, Doug Simons from the Richmond Seniors Advisory Committee. I just want to know that last presentation I very much like, and what I would like to do is to be able to show that, invite all my family, children 20 and over, sometime, and show that to them. And I see you have somebody over here photoing, recording all of this. Will that become available?
I think so, yeah. Yeah, I mean, you know, the most powerful thing that you can do for your family is to start a conversation with them about what we want at the end of our lives. Because oftentimes, as a healthcare provider, what happens for us is that we go into these situations and families have not started any kind of conversation, and often the conversation is happening in a crisis time, and it's not the time to have a conversation. So if we all could, it's a little bit easier said, obviously, but all get over our fear of talking about death. Talking about dying does not mean you're going to die. And by the way, getting hooked up with palliative care does not mean that you're in the last couple of days of your life or last couple of weeks of your life. What most people's conceptualizations of palliative care are that, you know, we go to them when we're almost, you know, on our way out. But in fact, palliative care can do so much more for you if you actually integrate that earlier. Thank you.
Thank you, Kelly. Just one comment is that we are recording the conference, and this will be available on the GRC website in due course. We've got time for one last question.
Hello, my name is Shashank. I'm a certified financial planner and also board of directors of Burnaby Hospice Society. Mm-hmm. One of the biggest challenges that I've faced is education. Like you rightly mentioned, people have all kinds of assumptions, and I have no clue how things are going to be panning out. Mm-hmm. I wonder if at any point in time there is a plan to introduce death and dying as or advanced care planning or palliative care as a part of school education. Yeah. Just like sex education, yeah. I think the implications are larger, if not equal. There's no comparison, of course. But time and again, I always face a huge challenge around this issue, both professionally and as a volunteer. So appreciate if you have any views you could present.
It's a really excellent comment, because, you know, when I was highlighting sort of the historical perspective, there was a point in time at which dying and death was openly discussed in the family. It wasn't feared because people saw this happening in their communities. And when we started to institutionalize and medicalize death, we kind of packaged it up in this little place that we now don't talk about. So children have very little exposure to dying and death. And you know, I think Lorraine will have something to say, and Doris Barwick also will be here this afternoon from the BC Centre for Palliative Care. But it is that kind of education that needs to start with our children, because dying and death, if we want to be able to promote good quality care at the end of life, must be normalized as a normal, natural part of our life. One thing's for certain, we're all going to die. So, yeah, thank you.
And on that note,
yeah.